Hello everyone, my name is Colleen Wong and welcome to Health Equity Teachers video on care for non-English speakers. Language barriers are one of the most important barriers to accessing care, so this is an important issue. Let's get started. Here are the learning objectives for this module. Describe the current demographics of non-English speakers in the US. List and describe disparities in healthcare access and the clinical consequences of language barriers experienced by non-English speakers. Describe strategies for communicating with non-English speakers in the clinical setting. Describe the different types of medical interpreters and how to get certified as a medical interpreter. Summarize strategies to address language barriers in the clinical setting, including medication management. So first of all, who makes up the non-English speaking population in the United States? In general, the limited English speaking population is large, diverse, and growing. So these issues that we're going to discuss aren't going away anytime soon. Including those who are non-citizens, 66 million people spoke a language other than English at home. And if you limit this figure just to Americans, the number is still 60.5 million people aged 5 or older who speak a language other than English at home. Spanish accounts for 62% of people who speak a language other than English at home, but there are more than 380 languages spoken across the United States. And because of changes in immigration patterns, other languages such as Vietnamese, Russian, Persian, and Armenian are more likely to be encountered. There's a lot of variation in English proficiency between these people who speak a language other than English. Some people may be completely fluent in English and other languages, while others may have what is known as limited English proficiency. So limited English proficiency, or LEP, refers to patients who cannot speak, read, write, or understand English at a level that permits them to effectively communicate with healthcare providers. The US Census uses a set of standardized questions to ask about language ability, and anyone who speaks English less than very well is considered LEP. Said another way, those who report speaking English well, or not at all are considered to be LEP. That being said, in clinical settings, you want to ascertain LEP status. So don't assume LEP status based on how a person looks, if they have an accent, or anything else. You need to ask. Step 1 is asking, how proficient are you in English? And step 2, for those who report that they speak English less than very well, ask the patient to report their preferred language. The proportion of people in the various language groups who are LEP varies. More than 50% of Chinese, Korean, and Vietnamese speakers and 46% of Spanish speakers have LEP. 20% or less of French or German speakers in the US are LEP. So there really is a lot of variation in English proficiency in the various language groups. In terms of location, the greatest concentration of LEP residents are in California, Texas, New York, and New Jersey. But the greatest increase in LEP populations between 1990 and 2010 has been in the southeastern and western states, which are still experiencing a lot of growth in the LEP populations. These emerging LEP communities have a relative lack of established language access services, and patients in these areas may face particular challenges. It's also important to mention that LEP individuals are more likely to be older, less educated, and have low income compared to English-speaking members of the same ethnic group. So, why does this even matter in the clinical sphere? Why does language matter when it comes to patient care? Studies have shown that history is a key component in the final diagnosis of upwards of 82% of cases. Language affects both access to care and the care received. The quality of communication affects patient and physician satisfaction, patient adherence, and clinical outcomes. And we're going to discuss these factors next. When compared to English speakers, limited English or non-English speaking patients are less likely to be insured or to know about public insurance. They are less likely to receive doctor visits, dental care, eye examinations, mental health visits, or referrals from the emergency department. There is also an impact on the provider-patient relationship. Even when limited English-speaking patients are able to access care, they are less likely to understand what occurs in the clinical encounter, from basic medical terminology to discharge diagnosis to prescribed medications. Patients with language barriers are less likely to engage with their providers or feel as if they've played an active part in decision making, and therefore, they are less likely to be satisfied with their care. In nearly every clinical setting, language barriers also appear to result in lower quality of care. Those who speak limited English are less likely to get preventative care such as mammograms, pap smears, cancer screenings, and vaccines. In psychiatric settings, LEP status has been associated with inadequate evaluation and diagnosis. And for those who are undergoing palliative care, the LEP patients are less likely to have adequate pain and symptom control. When LEP patients are hospitalized, they, on average, have longer lengths of hospital stays, increased risk of falls, more central line and surgical site infections, and they are more likely to experience surgical delays. In the United States, patients have a legal right to language access in healthcare. On the federal level, Title VI of the Civil Rights Act of 1964 means that any healthcare organization that receives federal money, including Medicare or Medicaid, is obligated to ensure linguistic access. More recently, the Department of Health and Human Services has issued guidelines for providers determining what type and to what extent of language assistance services to offer. The Affordable Care Act explicitly requires insurers to provide written translation and interpreting services for LEP patients. The Centers for Medicare and Medicaid Services has issued regulations that require Medicaid Health to make interpreter services available free of charge. However, despite these legal mandates, there are still language barriers in health services. So what does one do when communicating with non-English speaking patients? First of all, there are some misconceptions about non-English or non-native English speakers. Just because someone doesn't speak English does not mean that they are less intelligent than someone who does. They are also probably not hard of hearing, so you don't need to yell. Okay, so whenever possible, use an interpreter. This will likely make things easier. We will discuss different types of interpreters because not all interpreters are equal, and how to become a medical interpreter if you're interested. When using an interpreter, still address patients directly. So face the patient and speak to the interpreter as if you were speaking to the patient. So use second person rather than third person. When you are speaking or communicating directly to the patient, so in an instance where you're using no interpreter, speak slowly and carefully. It is always important to make sure that you've been understood, but even more so when there is a language barrier. So repeat what you've said if you haven't been understood. Repeat exactly what you said because changing up the words can be confusing. If you need to reword your thought, indicate that you're doing so. Say something like, "Let me say that a different way," or "By that I mean." Of course, adjust this to your patient's level of English. When encountering difficulties communicating, it's important to stay calm. It can be frustrating as a provider, but it's equally frustrating and probably scary as a patient who doesn't understand what's going on. Try and use educational materials in the target language if available, in illustrations and models. We will discuss this last point some more as it's related to medication adherence and what we can do to help patients with medication management. We said, when available, use an interpreter. So what are the different types of medical interpreters? Well, the best case scenario is a bilingual clinician who is, in a sense, their own interpreter. When they can, those who speak limited English choose clinicians who can speak their language. And language concordance between physicians and patients has been shown to increase patient satisfaction, lead to better ratings of care, and possible medication adherence. But there is a limited number of truly bilingual clinicians, and there is a risk of miscommunication and misdiagnosis if a clinician overestimates their language skills. Sometimes people use bilingual staff, like secretary or medical assistants, as interpreters as well. This can be convenient, but there is a risk of inadequate interpretation if staff do not have sufficient bilingual skills or know medical terminology. This brings us to professional interpreters who are trained and tested in medical interpretation. But they may require a wait if there's an institutional imbalance of supply and demand, and sometimes there's no time to wait. Sometimes a patient's family member or friend is used as an interpreter. they would be what's called an ad hoc interpreter. Ad hoc interpreters have been shown to make frequent errors, including omissions, paraphrasing using incorrect words, additions, and inappropriately providing their own views. Family members and friends are particularly unsuitable when domestic violence or potentially embarrassing symptoms need to be evaluated. There's also an important caveat that minor children should never be used as medical interpreters because it places them in uncomfortable and frightening positions. So that brings us to how to become a certified medical interpreter. The field of medical interpreting is relatively new in the United States. There are two national interpreter organizations, the National Board of Certification for Medical Interpreters and the Certification Commission for Healthcare Interpreters. So if you're interested in becoming a certified interpreter, you can go through either one of these two organizations. Medication management is also an important topic to mention when talking about language barriers. In the office, you can use an interpreter, but health continues way beyond the office visit. Taking the right medications at the right time in the correct dosage can be difficult for any patient, but especially those who have a language barrier. There are many reasons why a patient may not be adherent to their medication regimen. Lack of understanding of the medication's proper use, lack of understanding of the reason for taking the medication, lack of understanding of the possible adverse side effects in conjunction with complicated instructions of use can all lead to suboptimal medication adherence. Other times, a patient may take many medications and leave out one in particular by accident. One way to help patients manage their medications is by providing written instructions for each medication in English for those who can read English better than they can understand spoken English or in the target language. Now, writing a med list in a different language can be difficult, and some things get lost in translation, so to say. So it can be helpful to use pictograms, diagrams, and models, such as a visual pill card with pictorial aids to help these patients with their medication management. And that concludes our video on care for non-English speakers. Thank you.